organizing team, Dr. Sridhar especially. Thanks for this opportunity. The redefining outcome has been the theme. I think it's so relevant. Whatever we do, we need to have a great impact on the outcome. And towards that, I think imaging and physiology has greatly contributed. Today, I'll be showing a case of bifurcation where imaging helps you to make so many decisions and also confirm to what you wanted to achieve when you set out. Have you achieved all those goals, or did you have to improvise? Can somebody play this, please? Welcome to Apollo Hospitals, Bangalore. Today, we have an interesting case of a 73-year-old lady who's been hospitalized multiple times for acute decompensated heart failure with preserved ejection fraction, frail, 46 kilos, borderline creatinine 1.4, and the LV ejection fraction is preserved. Most valves are doing well. Initially, they were reluctant, but following the second hospitalization for heart failure, it was decided to do coronary artery disease assessment and revascularization if needed. The angiography done shows critical stenosis of left main, which is heavily calcified, extending again into ostial circumflex and LAD, and also mid part of the LAD and OM2 have disease. The family was suggested bypass as the first option, but they did not want it. So hence, we would like to treat distal left main bifurcation calcified lesion with calcium modification with Abbott's Diamondback 360-degree orbital atherectomy. The primary component of a good revascularization result by PCI is good plaque modification and able to deliver a stent and having natural or maximum expansion without, complications. So that's where the calcium modification is very, very important. Imaging plays a very crucial role, and OCT defines calcium better than IVUS. Since it's in the distal left main, we choose to do an OCT at this point to understand the disease and take forward from here. In a complex lesion, if you have to take just one imaging, it's better to do it pre rather than post. Since it's a distal bifurcation, we think OCT would still be a very good option in distal left main, and also the calcium can be delineated or understood better with OCT. The Ultron 2 is a great enhancement in terms of AI delivered to imaging. And this is, you look at this, OptiStar, even in a critical lesion, it goes down so beautifully to give you unreachable accesses without predilation. You can still see a wonderful image qualities. We intend to do a saline OCT so that the contrast load is not too much. So we finished the OCT. Let's analyze the OCT images. Ultron 2, the great advancement has been most of the assessment can be done on a single screen. Very well co-registration done. Great automatic identification and enhancement of external elastic lamina as well as calcium. Yeah, let's talk about the OCT. You can see a pure saline OCT, no contrast. This is the distal left main. Keep going forward, please. You can see here there's a nodule between 3 and 6 o'clock. Keep moving, and again another nodule at 12 o'clock and another one at 7 o'clock. And look at the diameter. You're left with 0.75 millimeter, and the calcium arc is much larger here. You can see Ultron 2 clearly shows, and it's totally almost occluded vessel. Yeah. Yes. LAD ostium is also looking fairly all right. Keep going down into the circumflex, please. There's a nodule right at about 9 to 12 o'clock. Keep going down. Yes. Still calcified, but relatively healthy segments there. Yeah. That's again diseased segments. Keep going down, keep going down. Oh, it's almost more than 280 degree of calcium. We keep going and see the diameters. Now we know it's a very calcified lesion and calcium modification is obligatory. And when you look at the circumflex ostium, since the calcium ablation can be done both antegrade as well as retrograde through orbital, it's a most preferred choice if that can be done. Coming to orbital atherectomy, you must understand calcium modification. There are few tools, including rotablator, which is a forward-looking calcium ablating mechanism. Orbital atherectomy is different. It's a crown mounted eccentrically. It's about 1.25 millimeter, which can be antegradely or retrogradely used with speeds of 80,000 or 120,000, to which does two kinds of plaque modification. One, the sanding or grinding away the calcium, creating larger lumen. At the same time, there's an orbital action also, banging on the wall, which causes multiple fractures, increasing the compliance of the vessel, which helps you better expansion and delivery of the stent. So it's a dual mechanism, calcium ablative as well as orbiting, increasing the compliance. The crown is eccentrically mounted, not at the tip. So it's not a forward spinning alone mechanism. There are 4 components for an orbital atherectomy. There is this pump, then there is this crown, orbital crown, and then this is handle, which helps us to advance, and fourth, the wire called the wiper wire. It has its own great advantages. Let me just show you. Wiper wire is a 0.012 wire. It's much more easily deliverable than a rhoda wire. Our coronary angioplasty wires are 014, but this is 012, the body, but the tip is 014. So that's why you need to keep the crown always away from the distal dark tip. That's because if the crown comes in contact, it can ablate that and disconnect it. And this wire can also be used to do an angioplasty if need be. This has been an advancement over the rotablator. Why? You look at an advancement when either in terms of use it's much easier, or immediate result you get better, or there are long-term better outcomes. This seems to have achieved all the three, especially the ease of using. Here, one operator can do most of it by themselves, and everything is at your disposal, not one at foot. So here, you can see the wiper fluid coming out. Then there is a lock, which can lock the wire. Then there is speed control points, which can help you to spin at least at times 80,000, or when you want at 120,000 RPMs. Also, you can use it as a glide. If you keep pressing, it becomes a blinker when it rotates at 5,000 RPM. That 5,000 RPM is not enough to do what we call ablation, but just enough to advance. Knob is locked 1 centimeter from the most proximal end, and then advance you can see here, if you press long enough, it starts blinking. That means the RPM can start at 5,000. Then you open, start at 5,000. You can keep advancing as a single operator. Once you decide to start ablating, you need to lock the wire in place. If you do not lock, it will not start orbiting. So now we intend to start with 80,000, and then if need, we move up to 120,000 RPMs. The principle is do the sanding for about 15 seconds and give a break for at least 30 seconds. There are some ST depressions, so we wish to take it down. The one important thing is do it very, very slowly. Focus on my hand, please. You can see here, you can see the slower you go, more time you spend, you're going to have better ablation. Since it's going to orbit, not just plug the tightest portion, there's always some flow of blood which keeps flowing around, which takes the debris down, and there is chance of slow flow is much lesser, chance of bradycardia is much lesser. Wherever it engages maximum, stay there and then start retrograde so that you get wire biased on both sides and it gets you a larger ablative force. There's also lesions down here. We would like to clear. You can see the noise. We'll just take one small cine. Okay. The circ lumen looks already large. I think now I'm going to spend more time on the distal left main. Here we are going to go to 120 because it's a larger diameter left main. There's a great modification that has happened. Wow. It's a beautiful ablation that has happened at the circ ostium. Yeah. So I think now we have to carefully cross it to the LAD. If you put it on the glide mode again, you can see there the wire is very, very stable. And I can take out my catheter very, very smoothly. Pushed over. We do one more OCT to left main to see how well the plaque is already modified. Here you can see the left main osteoproximal region. We had already seen. You can see here we have already modified the plaques. There are small cracks, superficial cracks that have happened. And distal, there must have been some impact. That's at the circ ostium. You can see widely opened at the circ ostium. And there's a nice eccentric lumen gain that has happened at that place. Yeah, there's one nodule between 12 and 3. Keep going distally. I think that's reasonably broad. It's changing to wiper wire. It's a good lumen. Yeah. There's calcium, but lumen is still good. 5 millimeter square. I think we're, just go at the diagonal origin, please. Just after the diagonal, show me what is, that's a diagonal there's almost 360-degree calcium, but what is 2.5, 2.6 is the grinding. So, looking at the complexity, should we deal with it or not is the question. The left main, I just want to get slightly larger lumen, and the ostium of the LAD. One good thing about atherectomy is it does not really cause severe dissections. Recrossing very often is easier. 6, 8. Just 10 atmosphere. You can see how beautifully it is. There is no need of cutting balloon or any other plaque modification. Just at 10 atmosphere, this speaks for the orbital effect of the orbital atherectomy, that you don't need too many tools, because most often after rotation, after rotablation, we have to use a cutting balloon because it just creates a passage. See how beautifully the stent crossed. The beauty of Zine's platform is that, you can precisely position at the ostium. Sure. Before you crush the side branch stent, use an NC balloon to make it the broadest that it can become. Don't crush not fully opposed stent, because it may become difficult to recross. So we are crushing the LED stent. Come back. You can see that we just crossed into the circumflex from the left main across the crush stent. We'll do a first kiss. Decay crush. So after the first crush, you take out everything, put a stent into the main vessel. Here we have made left main to circumflex as the main vessel because the diameter is much, much larger. Yeah, that's good enough. Deliverability of the stent. At just nominal pressures, the vessel is beautifully expanding. What you have to understand when you do the final kiss, you should not be distal crossing. It should be non-proximal but quite close to the proximal. You saw that. That's a great crossing, and that's where we wanted to go. You can see on the OCT that orbital atherectomy made our case very, very simple, where we just had to do good multiple runs of orbital sanding as well as orbital motions, which both debulked, ablated the calcium, and also significantly changed the compliance of the left main as well as the ostial circumflex and LAD. Here we learned that the best way to do orbital for distal left main, ostial LAD and ostial circumflex is more retrograde than antegrade. And we also have great expansion, large lumen areas available without any struts across the osteo, both LAD and circumflex. And we didn't have to use anything apart from an NC balloon post-orbital for calcium modification. Probably if it was rotablation, we may have to use a cutting balloon. Again, OPNC possibility could have been more than this. Just at 610 atmosphere, following the orbital, we could get a complete expansion of NC balloons. One good decision can give you a great day. Thank you. I think imaging is, thank you. The imaging plays a vital role for you to strategize, because to achieve great outcome, understanding the plaque morphology and your strategy of how would you modify to the maximum so that stents can do only scaffolding, but they don't do the bulwarking of expanding and gaining the lumens. Thank you, Chairperson.
A great case, Girish. I think you made your points very well regarding the orbital atherectomy. If you got to use one device to get you cracking and get a larger lumen, probably that's the way to go. And good images also.
Thank you. And it was a saline OCT all through.
Yeah. That is fantastic result. There are a lot of discussion about saline OCT, whether we can get good opacification or not. But you demonstrated in the left main also, you can get a very good picture. And your technique of orbital atherectomy was very excellent. Result was fantastic. Congratulations.
What is the volume for the saline OCT in this case?
What is the volume of?
Volume of the saline
that we use. I use a 50 cc syringe with 30 ml saline in that. I land up injecting about 15 cc. You get a good image. If you just take a 20 cc, it goes too rapidly. I think take a longer one and sustained injection in a 50 cc at about 30 ml will be good.
So this is what we learned in our trial also. In saline OCT, in a very tight lesion, it works better than contrast.
Right.
And one addition that when you in a secondary cross in decay crush, it should be as close to carina so that you have a minimal length of new metallic carina if you want to have a good side branch outcome. Because with all the steps of decay crush, we published in OPSIBLE left main study, the biggest disadvantage is that we are getting a longer new metallic carina leading to side branch ISR. if you want to have a shorter neometallic
Neocarina.
you should go as close to carina as possible.
Possible.
Yes, but before that you have to follow all that steps we have published in Modified DK Crush, a double PSO, double pot. So you have got a good side branch ostium areas also.
Thank you.